Sorry. Hi, everybody. Sorry about that. I'm just compounding the issues today. So thanks, everyone, for joining. And I want to thank Dr. Roy for her grace under pressure, and thank David and Andre for getting us technically ready to go. I'm really excited we have Dr. Roy joining us today. I have known Durga since she was a fellow at Hopkins Bayview in 2012, and it's really been a privilege to work with her as a colleague and really see her career develop. And she's really, this is a great topic for us. I mean, as we all know in our clinics, we probably see so many people with mild traumatic brain injuries, and it kind of, exists with a whole bunch of other problems. And it's really something important to think about.
Sorry, Dr. Morano, you're muted.
Okay, can you hear me now? When did I go out?
You said there was something to think about?
Oh, okay. Well, I'll just start. Sorry about that, everybody. So let me do the formal introductions, and then I will turn off my camera and my microphone, and we can be on. So Durga Roy is an assistant professor of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine, and she is the medical director of the Johns Hopkins Neuropsychiatry and Brain Injury Clinic. And she is also the medical director for the Head Injury Outpatient Psychiatric Day Program at Bayview, which is something that she worked on developing, and has really been a kind of a unique program in the area. Durga wears many hats, and she's also the director of education for the Johns Hopkins Psychiatry Internship, and the director for the Consult Liaison Psychiatry Fellowship at Johns Hopkins University School of Medicine. Durga is a board certified in general adult psychiatry and consultation liaison psychiatry. She has authored numerous peer-reviewed publications focused on neuropsychiatric outcomes after traumatic brain injury. Her area of research interest focuses on the neurobiology of depression after traumatic brain injury and the study of prognostic factors for depressive symptoms after traumatic brain injury using resting state functional neuroimaging. And I can say, having known Durga for a while and worked with her, we talk about triple threats, and Durga certainly is. She's a very active educator. She directs the internship and has been really highly academically productive with her educational work. She does a lot of clinical work and developed this great day program. And currently she has a NARSAD Young Investigator grant looking at changes in functional connectivity after acute mild traumatic brain injury. And I think what's kind of unique about this is that she's actually collaborating with ED docs at Hopkins to recruit patients with mild TBI in real time when they actually present to the ED. And last but not least, she is also the past president of the Maryland, DC chapter of the Indo-American Psychiatric Association. So with that, I'm going to stop talking and turn off my camera and turn everything over to Dr. Durga Roy.
Thank you, Chris, for such a great introduction. I just want to confirm, can everybody just put your thumbs up if you can hear me? I just want to make sure. All right. So I'm going to talk today about, as Chris mentioned, something that can often very easily be overlooked in psychiatric patients that suffer traumatic brain injury, which is this idea of mild TBI, or mild traumatic brain injury, and speak specifically about the neuropsychiatric aspects of concussion. I want to point out that just before I give you this talk, that a large majority of patients that do suffer concussion do tend to recover, but there is a measurable majority of people who do suffer, and those consequences can be debilitating. So we'll talk about some of those consequences, but just wanted to put that disclaimer out there that oftentimes there is recovery, but there is a large percentage of people who just cannot recover. You can advance the slide. Thank you. So I just have two disclosures. The first is that I've served as a consultant on the Avenir for Avenir Pharmaceuticals. And the second is that the the data that I'm going to show you today from our study is from a very large cohort that we studied at Hopkins, the head injury serum markers for assessing response to trauma. So I just wanted to put that in the disclosures as I am going to discuss the data there. And also the psychotropic and neuromodulatory interventions that I'll be talking about are actually not FDA approved for use in TBI, and many are often used label. Thank you. Okay, so for today, I would hope that by the end of this talk, we can help identify the common neuropsychiatric disturbances of mild TBI within the first year of injury. And by the way, TBI is the acronym that we're using for traumatic brain injury. We want you to be able to identify the clinical and demographic risk factors associated with who really develops neuropsychiatric problems within the first year after mild TBI. And finally, listing the pharmacologic and psychosocial interventions that we use to treat post-TBI neuropsychiatric symptoms. So let's go over TBI, the problem itself. Before we discuss TBI, we kind of have to talk about the definition. What is a TBI? So TBI is actually, and the definitions have been in flux throughout the TBI literature, but really most people agree on the fact that it's a traumatically induced physiologic disruption of brain function. And it's really manifested by at least one of the three following symptoms. Any period of loss of consciousness, and you can ask the patient, did you black out? Any loss of memory for the events that happened either before or after the accident, which we call post-traumatic amnesia. And any alteration in mental state. Usually the way we ask this question to the patient is, are you feeling dazed, disoriented, or confused? These questions are very important because these symptoms are really what help define the severity of TBI. So people who have very short periods of these symptoms are more on the milder end of TBI spectrum severity versus those who have it for longer periods like days or weeks are more in the severe spectrum of TBI severity. Thank you. So as I mentioned here, we're looking at certain criteria, loss of consciousness, altered mental state, post-traumatic amnesia, and how long those things are lasting for or present for really define whether it's mild, moderate, or severe. Now, there are several definitions which I'll talk about in terms of criteria for mild TBI, but the most commonly used is the VA-DOD, or the Veterans Administration Department of Defense definition. And as you can see here, structural neuroimaging is typically normal for mild TBI. And in addition to having brief periods of loss of consciousness, altered mental state, and post-traumatic amnesia, a Glasgow coma scale is pretty high, so from 13 to 15. And if you remember, the Glasgow coma scale, the higher the number, the better you are. So TBI is a big public health problem. About 3.6 million TBIs occur in the U.S. annually. And of this particular group, about 3.2 to 5.3 million people living with TBI-related disability exist. And this can mean that they have problems with functional outcomes, with psychological outcomes, psychiatric outcomes, cognitive outcomes. Over 60 to $221 billion are spent a year in annual direct and indirect medical costs. So this is a very expensive disease. We're thinking about people coming into the ERs, getting diagnostic workups, staying in the hospitals for long periods of time, and incurring high medical costs. About 43% of those who are hospitalized for TBI subsequently develop some kind of functional or psychological sequelae, which we will be talking about. And it's really the leading cause of death and disability in people who are younger than 45 in the United States. So if you work in a trauma center, you work in an emergency department, you should expect that young people under 45 really have a high risk of death and disability from the TBI. Next. So TBI can be caused from several things, but the most common, the top two reasons that we have people come in from traumatic brain injury are falls. As you can see from the geriatric population, these patients can often be orthostatic, can have unstable gait, and are very susceptible to falling and incurring an injury. and motor vehicle accidents. So those are the two sort of most common reasons that we see TBI. Now, we all live in Baltimore, so we can appreciate that assault rates are very high, and that's another reason we need to consider patients coming into us with these types of symptoms. And finally, as we all are aware, in the media, concussions and sports-related injuries are also something that are kind of making the news and becoming very significant. And that's an important thing to consider as well, even when you talk about non-professional leagues and sort of local sports as well. When we think about TBI, we have to think about why do we want to actually treat psychiatric problems after TBI. So we can think about it sort of as a triple threat. So you have this devastating consequence of this head injury, this trauma to the brain, actually. Not all head injuries are actually brain injuries, but you have this trauma to the brain, and then you combine it with psychiatric problems. Either the patient may have had psychiatric issues before or after the injury, but combined together, they create a significant amount of disability. We see people with significant occupational problems, getting back to the jobs that they used to do, integrating into society socially. You know, the patients with impulsive and sort of disinhibited comments can sort of have problems integrating back into their social circles. Workforce participation is a big problem. Patients have a hard time doing the tasks that they were easily able to do before. And finally, they have issues with activities of daily living and doing the tasks on a day-to-day basis that they were able to do to live their normal lives. Next. So when we think about the neuropsychiatric problems that can happen after TBI, we can sort of put them into four big buckets. There are emotional consequences that happen. This is sort of when we see affective lability, mood dysregulation, and irritability. Cognitive issues, a lot of times we see problems with processing speed, memory, executive dysfunction, focus, and concentration. We see problems with behaviors, so lots of impulsivity, aggression, disinhibition. This is more with people with severe TBI, but it's still something to think about. And finally, physical problems. So if you got hit in the head, it's very likely that you also had a body injury. And so physical consequences like pain syndromes, et cetera, are also something that's really important to think about. This is an important slide, and the one thing I want you to take home from this is how well a patient does after a traumatic brain injury depends on what happened before the injury, at the time of the injury, and after the injury. These are all very important factors that play a role in the outcomes that happen within the first year or two after TBI. Next. So what is it that psychiatrists need to know about mild TBI? I went ahead and started off by telling you majority of these patients recover. Well, it's important to know because mild TBI actually constitutes the majority of all TBI. So if a patient had a TBI, it's very likely it was mild. About 70 to 90% of patients suffer just a mild TBI. 42 million mild TBIs are sustained worldwide every year, and about 100 to 300 of 100,000 percent population are actually hospitalized. So it's not really insignificant. The challenge with these patients is that their symptoms can be refractory to treatment. In other words, if a patient comes in, had a concussion, and then develops depressive symptoms later on, they may not respond to the antidepressant interventions that somebody would say idiopathic depression might actually respond to. I also want to point out here that the words mild TBI and concussion often are used interchangeably, but there is controversy surrounding that. For the purposes of this talk, I am using them interchangeably, but just for you to know that out in the TBI literature, there is some back and forth about whether they really are the same thing. But generally speaking, we do use them interchangeably. The other issue is that patients can often, because it's such a brief period of loss of consciousness or brief altered mental state, their symptoms can get overlooked. Oftentimes they can get brushed off by their providers and say, well, you just had a brief hit to the head, you'll be okay. So that's a big problem as psychiatrists because then they come to us with all of these other sequelae that we then have to manage. And there's great variance in persistence and severity of post-injury symptoms. So while some recover, several of them may persist with symptoms for years on out. I can tell you a large percentage of patients that I see in my clinic had just one mild brief TBI several years ago, but I'm still treating them for post-concussive symptoms. And the consequences can be devastating. They can still lead to suicide, poor rehabilitation, poor occupational and cognitive functioning. Next. Now, as I mentioned before, we typically go by the VA-DoD criteria for mild TBI. Again, very brief periods of loss of consciousness, altered mental state, normal imaging, and post-traumatic amnesia. But I do put this slide up for you to be aware that there are other classifications of mild TBI. The American College of Rehab Medicine, the Mayo criteria, and the WHO all have also created their own definitions, which are almost pretty similar to the VA-DoD. But we typically go with VA-DoD because across the literature, that's often very often used several times to sort of define mild TBI. It's important to also think about the type of injury. So when we think about hits to the head, we can sort of differentiate them between focal and diffuse. Focal is when we're looking at one tiny point in the head that gets an impact and results in either some kind of a contusion or a hematoma, as you can see on the left. So subdural or epidural or intracerebral type of hematoma. Versus diffuse, when you see a concussion, if you think about the brain, which is this jelly-like substance that's trapped in this hard encasement called the skull, it's sort of bouncing around in there. And the bouncing around can kind of cause what we call diffuse axonal shearing. As you can see on the bottom right, there is an axon that's completely normal and its integrity is completely intact. But then after the shearing that happens when the brain jiggles around in the skull, we can get this kind of axonal, diffuse axonal shearing or DAI, diffuse axonal injury. Next. So what ends up happening is a lot of the symptoms that develop after the injury itself is create sort of a constellation of symptoms called post-concussive syndrome. And the symptoms are headache, oftentimes we see. We can see irritability, dizziness is one of them. Fatigue oftentimes is something that patients come and complain about. I mentioned irritability early on is something that we see. Anxiety and mood symptoms can develop, and this is one of the reasons they often come to the Hopkins Brain Injury Clinic. Insomnia is a big problem that happens. It should be treated very early. Loss of concentration and memory is a big issue. And then finally, we have things like tinnitus, ringing in the ears, blurring of vision, and a lot of neurological symptoms that can happen that result in problems. Noise and light sensitivity is another one that people complain about. Next. So as I mentioned before, and I kind of keep handing on this point, is that often with post-concussive syndrome and symptoms, the symptoms resolve within 7 to 10 days. That's sort of the average. So about 80 to 90% of individuals have their symptoms resolved pretty early on. But there are about 10 to 15% of cases with prolonged symptoms that really last beyond 3 months. And if the symptoms are lasting beyond the 3-month mark, we call that persistent post-concussive symptoms or persistent post-concussive syndrome. And it's a big deal, actually, because functional impairment can be up to 33% at 3 months and 22% at 1 year. And as I mentioned, my clinic is filled with patients like this. So what are some of the risk factors? Who is at biggest risk for developing post-concussive syndrome? Well, what's been studied, at least very briefly in larger mild TBI cohorts, is people with poor education, substance abuse, prior TBI psychiatric history, so people have some diagnosis of depression or anxiety before, they're at higher risk for developing post-concussive syndrome later on. Oftentimes, comorbid sleep, cognitive, and mood disorders can also really present as a higher risk. People who are older and more adolescents, and adolescents is a very vulnerable population, they're also at risk for developing post-concussive syndrome. A study that was done in 2014 revealed that females tend to have more risk for developing post-concussive syndrome. And then there is this concept of something called a complicated mild TBI. I mentioned before when we talked about the VA-DoD criteria how neuroimaging is typically normal. But there are a subset of patients who can have some kind of findings on neuroimaging, evidence of a contusion, a hematoma, or some level of diffuse axonal injury, while still having very brief periods of loss of consciousness and altered mental state. And those patients are still classified as mild TBI, but because there is some level of imaging or abnormality, they fall into this quote unquote complicated mild TBI. And then finally, repetitive TBI. As you can imagine, a single mild TBI is easy to kind of recover from oftentimes for some patients, but if there's mild TBI, repetitive types of injuries can really add on and become accumulative and result in a lot of psychiatric problems later on. So there's different ways that we can sort of assess post-concussive symptoms. There are 3 common scales that are used. The first is the Neurobehavioral Symptom Inventory. You may have or may not have heard of this. This kind of captures psychiatric symptoms that happen. It does speak a little bit more to affect and apathy and disinhibition, but it's a really it's a good scale to kind of capture neuropsychiatric sequelae. The River-Mead Post-Concussion Symptom Scale, that's a very important one, and I'm going to talk about that because that's the one that we used in our study. It's a 16-item test that looks at all the neurological and psychiatric symptoms: headache, fatigue, irritability, depressed mood, anxiety, ringing in the ears, light sensitivity, and things like that. And then finally, the Post-Concussion Symptom Scale, which is very similar, looking at an itemized number of symptoms that you may or may not develop. Okay, so basically, what's important to note is that neuropsychiatric problems after concussion, again, we talked about those 4 big buckets, and I'm going to hone in on the 3. But basically, there are emotional, behavioral, and cognitive problems on more of the mild end of the spectrum, but still very debilitating. So emotional problems that we see are mood symptoms very often: sadness, anxiety, low vital sense, that's, the general self of well-being, low self-attitude. Behavioral problems like disinhibition, impulsivity, substance abuse. And then finally, cognitive problems. A lot of times, even with mild TBI, we see the slower processing speed, poor verbal learning, and impaired executive function. So the most important psychiatric phenomena after mild TBI is depression. It's the most common, and the prevalence range is pretty wide. And the reason that you see that it's so wide, from 13 to 53% within the first year after injury, is because the studies that looked at these cohorts actually looked at patients who had a pre-existing history of psychiatric illness. So they were really, truly heterogeneous samples in the population. But that's why that the range is so wide in this particular cohort. And then it really still has devastating consequences. People who have developed depression after mild TBI still have an increased suicide risk, impairs activity of daily living, and poor social, occupational, and interpersonal functioning. And who's at risk for developing depression after TBI? Very, very similar to the risk factors that we saw before. So poor education, people who are older, substance abuse. One difference is people who are male actually have a higher risk for depression after mild TBI, which is different from post-concussive symptoms because those are more females that are likely to develop. Pre-TBI psychiatric history by far is the highest risk because if you had something prior to the injury, you'll develop it after the injury as well. And then comorbid sleep and cognitive disturbances are also a big issue when patients are, developing these sort of in parallel after the TBI, can contribute to depressive symptoms. All right, next. Okay, so now I'm going to go ahead and talk about a study that we did at Hopkins that really looked at a very large cohort of people with mild TBI. It was a prospective longitudinal cohort, and it was called the Head Injury Serum Markers in Response to Trauma, or the HeadSMART study. So the primary focus of this study was to really look at blood-based biomarkers and whether or not they predicted outcomes after traumatic brain injury. And I basically analyzed the data specifically focusing on the mild TBI aspect of this cohort to really try to understand, and our group is continuing to try to understand, what is unique about this patient population? What are the characteristics that are in these patients that really lend themselves to developing symptoms later on and poorer outcomes? So we basically screened 4,452 patients. So in 2 different ERs, the Johns Hopkins Downtown ER and the Bayview ER, combined together, we screened about 4,452 patients, and about 1,374 were eligible. Finally, at the end of the 2-year study, we had ended up, when you looked at the whole 2 years, we enrolled 500 subjects. And just as consistent as what I've been telling you with the literature, the majority of those 500 subjects had mild TBI. And we used the VA-DOD criteria, again, to define whether or not they had mild TBI. So again, we went back to the definition of the VA-DOD, and they had to have at least endorsed having a loss of consciousness, or LOC, altered mental state, or AMS, or post-traumatic amnesia. And then imaging was typically normal and the Glasgow coma cell. But the three things that we were really defining presence of mild TBI was the loss of consciousness, altered mental state, and post-traumatic amnesia. So of the 500 subjects, 407 met criteria for mild TBI. And what we ended up doing was subdividing them into 4 different subgroups. We wanted to look and see whether the presence of loss of consciousness, which is a critical thing to really call yourself, to really define a TBI or mild TBI, and altered mental state, whether the presence of LOC and or AMS predicted outcomes within the first 6 months after injury. So we categorized them as groups that had both LOC and AMS, LOC only, and AMS only. And the group that had neither were the ones that had post-traumatic amnesia but didn't have either LOC or AMS. We used, as I mentioned, the River-Mead Post-Concussion Scale. And again, this is a 16-item checklist. We sort of looked at symptom severity. Based on the ICD-9 diagnosis, we lumped a lot of the symptoms into categories, and patients were considered to have significant post-concussive symptoms if they had mild or more severe problems in any 2 of these listed categories. Headaches, dizziness, general malaise is category number 1, irritability is category number 2, subjective complaints of concentration or memory, category 3, insomnia, category 4, reduced tolerance to alcohol, category number 5, and then preoccupation with these symptoms and fear of permanent brain damage, category 6. So in conjunction with the River-Mead Post-Concussion Scale, we use these sort of categories that are listed in the ICD-10. Another scale that we used was the PHQ-9, which is used for depression, as we've all been familiar with. So screening, diagnosing, monitoring, measuring depressive symptoms. Again, it's not to really diagnose depression itself, but depressive symptomatology. And the important thing to know here is that it's actually been validated for use in TBI. And in this particular case, in this particular study, we considered the scale to be the score to be clinically significant for depressive symptoms if the subject scored 5 or greater. So that was kind of considered clinically significant. And then the final scale that we used was the Glasgow Outcome Extended Scale. So this is basically a scale that's used to ascertain functional recovery after TBI. And what is functional recovery? Well, it's basically return to daily life activities, working, community, and social activities. And it's really characterized on a scale of 1 to 8. 1 is the lowest, which essentially means the subject is dead, and 8 is upper good recovery. And we basically dichotomized this particular variable and said that any score of 7 or less was defined as incomplete functional recovery, whereas a score of above 8 was defined as complete functional recovery. So what we found when we divided the 4 subjects or the 4 subgroups, if you look at basically the trajectory of the timeline, the patient would come into the ER with blunt head trauma, and then within 24 hours, we would recruit them into our study, and then we followed them at 1, 3, and 6 months. And the scales that we used were the River-Mead, as I mentioned, the PHQ-9, and the GHOST, because we were looking for whether or not there was any changes in the post-concussive symptoms, PHQ-9, depressive symptoms, or functional recovery, all based on the presence or absence of LOC and AMS. And what we learned was that of those with a history of depression, about 50% had post-TBI depressive symptoms. So this is pretty consistent with the literature that I shared earlier. Pretty broad range, but 50% is a pretty solid number. So we understand that these people had prior psychiatric illness, so they developed depressive symptoms afterwards. But what was interesting is that with people that did not have any prior depression history, 24% had new onset post-TBI depressive symptoms. So there was something right after the injury that explained or was associated with a development of about 24% of the subjects having depressive symptoms that were new in onset. And you can see at each time point, at 1 month, 3 months, and 6 months, that the prevalence continues to increase. Of course, at 6 months, it was the highest, but we also had the highest N, which is 240 subjects. But still, it was important to know that this is consistent with what has been seen in the literature of people who have depression after mild TBI. So when we looked at the 4 different groups, both LOC and AMS, LOC only and AMS only, what we learned from this was that the presence of both loss of consciousness and altered mental state together resulted in higher rates of depressive and post-concussive symptoms within the first 6 months. And the presence of both loss of consciousness and altered mental state resulted in the highest risk of incomplete functional recovery. So having both at the time of injury was very, very important because that actually put people at higher risk for these things. For those who only had loss of consciousness, interestingly, post-concussive symptoms was associated with LOC just at 1 month, but not at 3 and 6 months. And incomplete functional recovery was present throughout at 1 month and 3 months, but then not at 6 months. So this is indicating that LOC really as a variable can maybe predict things early in the injury course, but not much, so we call it in the acute injury phase, but not really in the chronic phase. Altered mental status, however, when it was present only, was associated with depressive symptoms both at 1 and 6 months. So the idea being that if somebody only had altered mental state, they were likely to develop depression at 1 and 6 months, both in the acute and in the chronic phase. And post-concussive symptoms, again, were only associated early on at 1 month. So what we learned from this is you really need to ask, did you black out and did you experience feeling dazed, disoriented, or confused in every clinical evaluation? Because it's important to know whether those 2 symptoms of LOC and AMS were present at the time of injury. LOC, it turned out in our study, only predicted post-concussive symptoms in the acute phase, whereas AMS predicted depressive symptoms both in the acute and chronic phase. So it might be that AMS is actually an important marker for determining what will happen within the first year. But of course, more studies need to be done. It's important because when we look at the presence of LOC and AMS at the time of injury, we really can identify who is at risk for post-TBI symptoms within the first 6 months. Okay, next. So now I'm going to move on to managing these symptoms, because as psychiatrists, that's pretty much what we're doing most of the time, right? It's important to kind of review what's important in terms of symptom management. So the main thing that I want to relay here is that management of mild TBI neuropsychiatric symptoms is multidisciplinary. Very important to know. As a TBI psychiatrist, I'm spending majority of my time in the clinic coordinating with other physicians of other specialties or other providers of other specialties. So PM&R, physical medicine and rehab, audiology, sleep medicine, neurology, pain management, neuropsychology. This integration of specialties is very important because the patient is not coming in just with isolated psychiatric symptoms. And management of all of these non-psychiatric issues really can improve their outcomes. When we do a neuropsychiatric assessment of mild TBI, we obviously want to take a very stepwise approach. So as we all do as psychiatrists, a comprehensive psychiatric evaluation, of course, a thorough history. Then we want to make sure we're doing a brief neurological exam. This may also include a cognitive exam. In the clinic, we do a MOCA, but if we think that they need more further evaluation, we send them to neuropsychology. We always want to make sure that we are sort of assessing and doing a problem-focused medical workup. So if they have symptoms that require further investigation, you know, they have sleep apnea, we send them for a sleep study, etc. We want to make sure we have lots of ancillary studies to help establish the diagnosis. Could these behavioral issues be because of post-traumatic seizures? And do we need to get them an AEG ordered? Oftentimes, the formulation has to be multi-pronged. We have to think about all aspects of the patient, that I'm going to talk about next, but making sure that we understand what are the aspects of the patient themselves that contributes to their differential diagnosis. As I mentioned, multidisciplinary treatment is key. And finally, I'm always oftentimes consulting and referring people. So in other words, patients who oftentimes have neuroendocrine problems, I'm sending them to neuroendocrinology to assess pituitary damage, et cetera. When we're formulating patients, as I mentioned, we want to do a very multi-pronged formulation. So this means we're looking at sort of the four perspectives or four aspects of the patient. What was their life event or their life story? Is this something that they're having a hard time adjusting to, and that's why they're having these depressive symptoms? Is it something that the patient is doing based on their behavior? Is it their personality or their temperament that's explaining this? Or is it purely the brain illness or the brain disease? So we always want to make sure that we're not just jumping to the fact that this is a mild TBI and that there's brain damage. There may be other aspects that are contributing to this. You always want to make sure you're incorporating medical comorbidities into the picture, because patients who have a lot of medical comorbidities are oftentimes less likely to come in treatment and be compliant, and that can be a problem. And also want to make sure that you're asking yourself how much of the current symptomatology can be explained by the TBI versus something that was going on pre-injury in terms of psychiatric illness. Okay. In terms of pharmacologic management, it's very important to remember that these patients are extremely susceptible to side effects. So you really want to minimize polypharmacy, fewest meds, lowest dose. You always want to start low and go slow. So whereas you might titrate somebody's sertraline much more quickly if they did not have a brain injury, you want to be cautious and maybe start at a very low dose and wait a full 6 to 8 weeks before you go up to the next very low dose. A therapeutic trial of all medications, you want to make sure you've given enough time for medications to work. You want to continue to reassess the symptoms, because that's an important aspect of how they end up doing in terms of their development. So you can go back to the previous slide. You want to consider drug-drug interactions. I think that's an important thing to remember, because they're going to be coming to you with other medications. Neurology may be giving them something for seizure prophylaxis, and you have to make sure that there's no interactions with the drug that you're giving them. They may be on pain meds from PM&R. So these are all things you want to be thinking about. You really want to treat post-traumatic headaches and insomnia very, very early on, because these are the two most debilitating physical symptoms that can bother patients, and they can feed into and bleed into the psychiatric phenomena. So it's important to treat those early. Now, there are several psychotropics that have been studied in TBI, but not so much specifically in mild TBI. So of the studies that have come out, and this year we just published a systematic review on all the treatment trials, including neuromodulation and antidepressant therapies that have been looked at. And with depression, at least, the most important thing to note is that sertraline and citalopram have actually been studied the most, and they do show robust evidence for improvement in depressive symptoms. Methylphenidate as monotherapy has also been shown in a study to actually improve HAM-D scores after a 6-week period. So that's something to think about as well. For patients who are experiencing PTSD, we see a lot of this in the combat veterans. Sertraline is one that has been really robustly studied, and any dose from 50 to 150 milligrams has been useful. For insomnia, we always jump to behavioral interventions first, CBTI, or looking at sleep hygiene. But if those things don't work, Ramelteon and Trazodone have also been examined. For apathy, this is not as common in mild TBI, but it can happen. It's more in the severe TBI cases, but methylphenidate can really help. And again, remember, apathy is the person that doesn't care, but they don't care that they don't care. So there's really no dysphoria associated with it. It's just a pure amotivation syndrome where the patient just doesn't care that they're not motivated. For memory deficits, donepezil has been studied and has shown some improvement, as has lisdexamfetamine. That's something that's also pretty effective in patients at 30 milligrams a day. For executive function, amantadine has actually been very well studied in severe TBI, but there are some reports in mild TBI, and I actually go to this medication often very early on because it is such an effective drug to help people really improve that execution of tasks and the sort of organization of daily living that they need to have to function. For inattention, methylphenidate is also used very often. And then post-concussive symptoms, gabapentin has actually been examined, as have tricyclics. But in the more recent years, gabapentin is really coming along because the symptoms of headache and, tinnitus and light sensitivity, et cetera, are really, really persistent in some of these patients, and gabapentin has been shown to be effective. Next. Some of the other interventions that have been looked at, and again, these are all off-label, but some of the newer things people are talking about. N-acetylcysteine, again, this is coming from the pine mark root, and so that's an extract that has been used. Paracetam, which is a neurotropic agent, which has also very recently been studied, and it has been shown to have some efficacy. Branched-chain amino acids, as well as hyperbaric oxygen therapy. Hyperbaric oxygen therapy is something a lot of my patients have asked for. The problem is the availability of it is not so robust and widespread. Dexabanol is also something that's been looked at, but the one study that was done had actually negative results. So medical marijuana and or any kind of the cannabinoids aren't really well studied, but it's continuing to be explored. Of course, physical therapy is always important. Cervical vestibular rehabilitation has shown some benefit. Aerobic exercise, at least right after a concussion, has been shown to improve return to play outcomes. And then neurostimulation, not too widely studied, but transcranial direct current stimulation and repetitive transcranial magnetic stimulation have also shown some efficacy and improvement in at least the post-concussive symptomatology that may happen afterwards. And of course, when we think of psychotherapeutic interventions, it's important to really think about the delivery of the method that we're using. We really want to focus, number one, in psychotherapy on re-scripting the perception of the life events. So it's kind of like a conversation of saying, we're not going to get you back to the way you were before the injury, but we can certainly get you better than you are now. And what is it that we can do to re-script how you viewed your own story? CBT has a lot of evidence for its use in mild TBI and TBI in general. And one thing to remember is, depending on the patient's cognition level, you want to make sure you're tailoring it and modifying it, because sometimes the assignments and the homework that comes with CBT can be somewhat daunting and challenging for the patient. Supportive therapy and behavioral activation therapy have also been used and have definite evidence for efficacy. Cognitive rehab has been widely studied in TBI and has substantial evidence for its efficacy. We send our patients to the downtown outpatient neuro rehab center at Hopkins, and I often tell my patients, I'm going to be sending you for a referral to the brain gym. So this is kind of, and patients actually use that word. Oh, hi, Dr. Roy, you sent me to the brain gym. I'm really finding it helpful, because this is where they're focusing on all the cognitive deficits and rebuilding the neuroplasticity that comes along with all the tasks that they need to do. So memory problems, forgetfulness, inattention, focus, these are all sort of the cognitive sort of exercises that they do downtown that really works well in conjunction with what we do in our clinic. And then finally, family therapy is important. Many times, care providers are so burdened and so overwhelmed with the symptoms that their patients are experiencing, and they really need help from us as educators as well as the therapists providing psychotherapeutic interventions. And finally, substance abuse counseling is really important. Substance abuse, as I mentioned, rises after TBI very often, and it's important to make sure we're helping manage those problems as well. Rehab is really important. And when I talk about rehab, I don't just mean physical rehab. I actually mean psychiatric rehab. And this is something that's really often overlooked. Because we're dealing with people who have emotional and behavioral discontrol, it's really important as psychiatrists to think about globally within psychiatry, what kind of things can we be doing to help the patient? So it's not just pharmacologic interventions and regular psychotherapy, it's actually also occupational therapy groups. It's doing skills for social reintegration. How can we prevent this patient from blurting out things that are inappropriate? Vocational rehabilitation, calling up doors and DARs and getting them plugged into tasks that they actually are able to do to build their self-confidence. Mindfulness-based cognitive therapy, looking at what's going on in the moment and helping them de-escalate their internal sort of frustrations. Psychoeducation, as I already mentioned, to care providers, really talking about what is a brain injury, what can you expect your spouse to now be doing compared to what they were doing before the injury, and what kind of expectations and standards should you have now. And of course, anger management is a very important piece of this whole puzzle to help patients really catch themselves in the moment, de-escalate themselves, and really prevent themselves from getting themselves into trouble because of the disinhibition and mood lability. So because of this, we've created at Hopkins a really comprehensive program that encompasses all of this, which is called the Head Injury Outpatient Psychiatric Enhanced Services. Our goal of HOPES, which is the acronym, is that we really want to minimize disability and maximize ability. So maximize the function and productivity in patients with any kind of brain injury. We take patients with any kind of acquired brain injury, stroke, seizures, tumors, and TBI, but a majority of these patients still have mild TBI in this program, and it's important to know because they're really still struggling years after their injury. It's a 12-week program, so they come in 3 days a week. They see their psychiatrist once a week, their therapist once a week, and then they attend the groups that I just kind of mentioned: mindfulness-based cognitive therapy, anger management, psychoeducation, social skills reintegration. So it's a comprehensive program that really is like a day program for these patients to get through. After the 12 weeks, we have a sort of little ceremony and a graduation to give them some sense of accomplishment, that they really came through this turmoil very successfully. And sometimes after the 12 weeks, patients are not better. So what we end up having to do is we put them through another cycle. When they are ready, we also have what's called a step down. And so they have the HOPE step down where they can continue to connect with the patients that they were in that cohort with. And, as they progress and transition back to once a month med management and weekly psychotherapy. So the goal of HOPES is really to provide the highest quality of care to patients with post-TBI mood, behavior, and cognitive problems. We really want to provide education and clinical training. We have neuropsychiatry fellows in our clinic, geriatric psychiatry fellows, the residents come through this clinic, medical students come through this clinic. So it's really a great teaching opportunity to have our trainees sit in and learn about what is involved in this multimodal approach. And of course, creating research opportunities to conduct studies enhancing the understanding of TBI depression and other TBI problems. And we are actually doing a formalized study where we're tracking the patients who start HOPES at time 0 and progress through the 12 weeks, looking at their symptom scales and seeing if they improve and comparing them to people who did not go through HOPES. The 3 A's that we think about in HOPES is sort of advancing wellness, accepting disability. Again, it's that conversation of, well, we can't get you back to how you were before, but we can certainly get you back to better than you are now. And really attaining their maximum potentials. What strengths do they have now after their TBI that we can really hone in on and help them set themselves up for success? As you can imagine, the disinhibition and impulsivity render these patients often going to the ER or hospitalized. And so HOPES also has the 3 R's, which is to really reduce utilization in the system, reduce hospitalizations, reduce ER visits, rapid symptom stabilization, really in this 12-week period in an intense environment. And we get patients from all over, so it's easy because you all are in Maryland, so we're next door neighbors, but we actually have patients coming from out of state as well. They'll park themselves in Maryland for 12 weeks and just do the program. We also get them from internally within Hopkins, our own brain injury clinic, our inpatient psychiatric unit, the outpatient neuro rehab program that I mentioned, as well as our PRP. So really, patients are coming from all over to engage in HOPES and get their symptoms better in a 12-week course. So where we're headed with TBI, and particularly mild TBI, is the key piece is really collaborating. Again, it's the symptoms that are not just the psychiatric symptoms, but sort of globally the physical symptoms and the pain symptoms and all of these other things that are involved. Having integrated care sites with collaborative clinics would be ideal, and that's really where a lot of models are heading towards. Even as it stands now, Bayview is 15 minutes from the downtown Hopkins campus. So when a patient comes to the HOPES program, then they have to shuttle themselves downtown to do the cognitive rehab, quote unquote, brain gym, speech language therapy, then come back. And so having everybody in one site would be very ideal for these patients. And then continuing intensive outpatient psychiatric programs like this that are really focused on psychosocial rehab is important. We also want to be doing a lot of early screening through novel neuroimaging. Chris mentioned my NARSAD study that I am currently conducting out of the ER, which is really like we did with Head Start, grabbing these people right when they have the injury and then actually imaging their brains to see what changes in connectivity are happening that predispose them later on to symptoms. And finally, really intervening early at the time of presentation. If we knew they had loss of consciousness, we knew they had altered mental states, we knew they're predisposed for psychiatric symptoms and psychiatric phenomena later on, why not just give them referrals right out of the ER? In terms of treatment interventions, as I mentioned, TDCS and RTMS are kind of on the horizon. We just need a lot more studies with wider and larger samples. And then some of the treatment trials that people are talking about are things like glutamatergic agents, vortioxetine, levomelatopram, and ketamine, which is obviously now being used often for depression, is also being examined and thought about in mild TBI. So in summary, though a majority of patients with mild TBI, majority of them recover, a measurable minority persist with symptoms that really persist after 3 months. What's important is that those with repetitive TBI are, again, at highest risk for persistent symptoms. So just one single TBI may not be as risky as several TBIs, but that's important to think about. These symptoms are very often overlooked. And despite that, within the first year, patients still suffer loss of quality of life, poor social functioning, and risk of disability. And then pharmacologic intervention should be very, very conservative. You want to start low, go slow, and really avoid polypharmacy, focus on targeting the acute symptoms. And finally, using psychosocial rehab and multidisciplinary collaboration is really a key piece to the intervention. So the next time you see a patient, you want to ask them, did you ever have a TBI? Did you ever lose consciousness? Did you ever get dazed, disoriented, and confused? And if they say yes, you always want to think about the fact that there's really nothing mild about a mild TBI. Thank you.
Thank you so much, Durga. That was wonderful. And I just wanted to open up to any questions anyone might have. So if you want to call your questions out, if you want to type it into the chat, please be my guest.
I'm a call out kind of person in general.
And Dr. Richardson.
I was wondering, for the course, obviously it's too early in the study that you guys did, but the course of the depression after a TBI, is it similar to like MDD, like 6 to 12 months and probably going to relapse? Or is it more like it happens this one time and then they may never need to be on antidepressants again?
Excellent point. So I think that basically, the difference is that at least from what has been, so first let me take a step back. So the majority of the studies that were done with TBI depression were really looking, there's a few that looked at within the first year, and then several that looked at 5 years out. But typically speaking, the course does not relapse and remit as often. And a part of that is because of that point that I made early, is that symptoms are often refractory to standard antidepressant treatment. So, typically what I see in my clinic is that my patients that came in for an intake 5 years ago, they're still depressed. I mean, they're not, their mood is quote unquote fine or better, but they still have sort of the vegetative state or vegetative symptoms of depression that haven't really improved much over time. So I would say that it's not as episodic as you would see with idiopathic depression.
Hey, thanks, Durga. I don't know if you have your chat up, but if you don't put it up, you're getting a lot of kudos. There's a couple questions from the chat. One is from Dr. Greenblatt. It seems that the amantadine studies were done with initiation of the drug within 6 weeks of injury. Do you typically initiate early on or wait until persistent symptoms manifest?
So ironically, I think 6 weeks is very early on. I actually don't even start it until they've been, that's a great point. I don't even start with, I typically start early in terms of decision-making early, but not course of injury early. So the studies were started within 6 weeks, but those were people who had severe TBI. So what I do is I wait for persistent symptoms to manifest. And the symptoms I'm actually talking about often are apathy and dysexecutive syndrome. If a patient is coming in and they're saying this is really problematic, I've teased out that this is not because of depression, this is not because of some other psychiatric problem, but it's purely a manifestation of orbital frontal cortex damage because of the TBI, then probably after 6 months, I'll probably start amantadine. It does come with its problems. It's got the seizure disorder. That's the other thing. You want to make sure that they don't have seizures. It does have seizure risk factors, and then it also has the kidney stuff. So I actually wait until the symptoms are persistent.
And I actually did a couple other questions in the chat, but I had a follow-up question. I was asking, what do you use to measure amantadine response? I mean, if we're talking about executive function, are you seeing improvements in their cognitive scores? Do you have some other assessment that you use?
Yeah, for executive function, I'm just looking at their cognitive scores. So we're just, and also they're oftentimes in conjunction at ONRP with the neuropsychology people. So they're kind of telling us how they're doing in their cog rehab. But yeah, we're just looking at all the scales that we do normally in our clinic. With the apathy, I consistently do the apathy evaluation scale, the AES. That tells me yes or no that this person is responding to, amantadine.
So we got one here kind of on the same vein. Wondering, do you often observe sensory motor deficits? And if so, what are the assessments that you use to evaluate them?
That's a good one as well. So basically, I do. Firstly, the first thing that you always want to do is do a full neuro exam. And so that's happening. That's kind of in that slide that I mentioned, the stepwise assessment. That should be documented on the initial intake. What sensory motor deficits are there? And then when you do that, what I oftentimes do is I pull OT in very early on, and I have them do a lot of their assessments with me in the clinic to kind of assess what areas. Is this an issue of vestibular reflex issues? Is it postural control? What exactly is happening here that we need to focus more on? Is there some kind of sensory integration exercise that we need to do? So OT is actually my kind of go-to when I identify early on that there are sensory motor deficits.
So we have another question about migraine. How often do you see migraine, and do you give it any sort of special consideration or treatment?
I see it very often. So we're fortunate to have a headache clinic at Bayview. So I'm oftentimes, it used to be Dr. Rosenberg, but he left, and then we had now Dr. Tarek. And so we often kind of just, in collaboration talk. When there is lack of access to a neurologist, I typically very conservatively start sumatriptan if it's absolutely indicated. And then make sure that a neurologist is following it. That's the one thing about neuropsychiatry is, we are psychiatrists and we do look at neurological aspects, but there are things the neurologist really should kind of make sure that the patient is also following with. So, but with migraine, I typically go with the triptans.
So we've got a couple other questions. One is there any impact on the life cycle of female hormone? And maybe I'm not expressing this correctly. So the impact of life cycle female hormone variations on TBI symptoms and recovery. Do you know of any impact on that?
So if I'm understanding the question correctly, I'm interpreting it as, is it more that, is there something that affects hormonal function, particularly with the female hormones? And the answer is yes. Which is why, so the pituitary, sitting like this tiny little ball right there in the cell basically has very, very high susceptibility of getting damaged, especially when I talked about that sort of coup contra coup and the swishing back and forth. So one of my initial, and you may want to think about this when you do an intake with a patient that might have had a mild TBI, I always get a pituitary panel. So cortisol, IGF, growth hormone, FSH, LH, because those actually can be impaired. Now, in terms of how it affects their cycle, the monthly cycle, that I'm not too sure, and sometimes I have to defer to neuroendocrine. But I'm constantly, sort of as my initial workup, ordering the pituitary panel and then connecting the patient with neuroendocrinology. Dr. Roberto Salvatore.
So, Thane, we have another question from Dr. Richard. I actually had the same question, and just as a little background, I know you work out of a community psychiatry program, a very large one. We have a very large community psychiatry program as well, and we often get people who come in with, they've had some head injury, yes, with a lot of other things. They also use substances, and I guess the question is the stimulants. Do you worry about one, do you prescribe them in people's substance use histories, and do you worry about increased risk of impulsivity and substance abuse post-TBI if you prescribe these? Did I say that right, Jane? All right, so go right ahead. She's going to let me know. Yes.
Right. Yeah. No, and it's a very legitimate thing to be thinking about. Yes, I always worry. I'm very, Chris knows this from my prescribing practices. I get very, very conservative and worried about even the mildest thing that can make the patient who's not even has a substance abuse history to kind of will be vulnerable to abuse. So the thing is that methylphenidate is quite effective in some of the common symptoms that inattention, focus, and things like that. I have not seen that abused very much. It's a tendency, there is a tendency for me to kind of say, well, it's less likely to be abused in this patient population because people are seeing that it's really helping them, but they don't actually want to overdo it because it can actually lead them to the, as you mentioned, kind of become more on the other end of the spectrum. What I certainly take into consideration is whether they had a history of substance abuse or not. I definitely avoid Adderall. I do not give Adderall very often unless it's really other methylphenidate it didn't work. And that actually comes back to my point about why I like amantadine so much, because you can't abuse amantadine, and it actually helps and does a lot of the similar things. It's very dopaminergic, just like the stimulants are. And actually that's my way of kind of circumventing any risk for abuse. I haven't, I've used Vyvanse quite a bit, but Adderall is one that I have noted that patients do have a tendency to get a little bit more revved up and impulsive on if it's abused too much. But it actually can, also be problematic in terms of making patients relapse.
Excellent, thanks. I had, if anyone else have any questions, put them in. I had one more. What about the patient who comes and says, hey, doc, I'm thinking of going to the cannabis dispensary. What do you think? Or will you write this for me? How, or CBD oil. What's your recommendations on that in patients with brain injury?
It's a common question. I get that at least a couple times a month for sure. So my answer to that is, and I can actually back it up because as I showed you, we've studied dexamethasone and it has not helped. So that's number one. But what I like to often say is that, and many times patients will give me the example of, well, my friend had depressive symptoms and CBD oil got them better. So then I kind of come back and say, well, unfortunately, we don't know much about the use of CBD oil or cannabis in brain injury, and it may very well be that their mood symptoms got better because they didn't have some of the issues or problems that you might have in certain parts of your brain. So I kind of put it back on and you have to be very careful because you don't want to say, well, you have a brain injury, so you're not going to respond like other people do. But it's kind of what we're trying to say is that we have to be very careful because your brain is more vulnerable to problems.
So anybody else? Max, Dr. Spaderna, go right ahead.
Hi, can you hear me?
Yeah.
Yes.
I was curious about donepezil because I only think about that as being used in patients with dementia. Since I don't really treat dementia patients, I honestly don't have a lot of skill set using it. Do you use it? And if you do you use it long term or just for a short period of time?
So interestingly, the patients I use it on are my younger patients. I have these really young 20-year-old or 30-year-old folks who really just have had again, we've done a lot of other measures. We've done cognitive rehab. We've done a lot of the non-pharmacologic interventions. And so it's been studied and been found to be effective, more so in severe TBI. I would say that my patients who have had the severe TBI tend to get more benefit from it than the mild TBI. And I keep it on for at least a year or two. And then if there is sort of, they've plateaued off or they're not really noticing much difference, only then do I taper it. But it typically is a long-term thing that I continue to keep them on for.
Thank you.
Mm-hmm. Sure.
Anyone else? No, I have one last question. I said, I think we, kind of probably run across some of the same patients. And I suspect some of our docs, particularly because they would like to reach out to you. Is it all right if I share your email so we can?
Oh, absolutely.
Okay.
Oh, please. Yes, do. Well, like I said, we're next door, right across, not right across the street,
Yeah.
right across the city of Baltimore. Absolutely. I think, what's one of the things, and I can only say this to this audience because we share the state of Maryland together, it's so hard for patients to find TBI treatment. And, all across the state of Maryland, they are going, they're going to psychiatrists who don't have the specialty and may not understand the nuances. So it is really important that they have very subspecialized care.
Excellent. Well, thank you.
Thank you for having me. I feel very honored.
Thank
you. I feel
Oh, Durga, check the chat before you leave. You have lots of, thanks.
okay. Thanks.
Thanks, everyone.